Thank you so much for joining this session. I am Dr. Azalai Israel. I'm a TTA provider at Public Strategy. I have the pleasure today of introducing your presenter for this session, Dr. Diane Foley. Dr. Foley has spent her professional career in the clinical practice of pediatrics with a focus on adolescent health. As an adolescent health specialist, she founded and served as the medical director of North Point Pediatrics, and as a clinical instructor for pediatric and family practice residency programs at the Indiana University School of Medicine. In addition to an extensive clinical practice, she served the nonprofit world in an SRAE program by providing curriculum development and instructor training. With that, I will turn it over to Dr. Foley.
Good afternoon, everyone, and welcome. And I want to thank FISB for giving me the opportunity to share with you all a topic that is very important to me. A big part of my career has been involved with very much what you are getting ready to embark on, and that is providing information and training and support to adolescents and young adults in your community, and particularly as it surrounds health. And our topic today is going to be looking at optimal health and how that fits into the sexual risk avoidance programs. When you think about Department of Health and Human Services and their motto, it is to enhance and protect the health and well-being of all Americans. Well, in addition, what happens with the administration and children of families is that that mission is to promote the economic and social well-being of children, families, individuals, and communities. And so again, when we think about the issue around public health, it really is defined in what society does to promote health of all the people, and not only promoting health, but also to ensure that there are conditions are there which everybody can be healthy. And so again, public health has been called the invisible profession. A lot of times people don't hear about it or think much about it until you are in a crisis situation. And I think we all, many people who had never really knew what public health professionals were have gotten a new sense of that over the past year as it has come to the COVID crisis that we have had here in our country. And so again, experts are called on to help understand how physical and social worlds work together to save lives. And they're part of an ongoing system that protects people, but overall really promotes healthy decision-making, healthy behaviors to help to promote long-term health for people. This is not a new science. In fact, as early as the early 1400s, one of the philosophers was well known for his conversation around the fact that prevention is much better than cure. Again, Benjamin Franklin, you probably heard this, an ounce of prevention is worth a pound of cure. So again, as we think through this, we promote health, we prevent disease, we encourage change in unhealthy behavior, and we focus this on large populations or large groups of people. Optimal health is further defined as the balance between physical, emotional, social, spiritual, and intellectual health. And it is, again, some people refer to it as holistic health, some people call it whole person health, but the idea is that all of your, all aspects of your life, of the adolescent's life, needs to be healthy in order for someone to truly be healthy. When we talk about this as a public health, in the public health space, really one of the most important things about this is to recognize that while this message is for the whole population, it is critically important to also recognize where that individual is on the spectrum of health. And the goal is to try to lead them to the area of optimal health or the best health wherever they are, wherever they start. What choices, what changes, what behaviors can they do in order to help them become more healthy? And that is the hallmark of the optimal health model. And when we think about optimal health in the whole situation, there are several steps that typically involve looking at an issue or a problem. First of all, the surveillance is answering the question, what is the problem? Many times that is brought to you just because of a very specific situation that happens in the community or in the state or the country. There's not really a huge, nobody really needs to wonder what the problem is. Many times also then you have to search a little bit to find out what exactly is the problem, that then your next step then would become to identify what is the cause of this problem. After that, the next step is you have to design some type of an intervention for this particular issue that you are dealing with. And in public health, we typically define the intervention in what we consider primary prevention, secondary prevention, or tertiary prevention. Now, the optimal health model that we're going to discuss today actually fits right into this intervention piece. And so I'm going to leave that for a minute. We'll talk about it more in just a moment. But what I want to go on to is the next step, which is so important when it surrounds this, because we can't just stay at our intervention step implementing it, but not trying to evaluate and see how did what we do work. And again, a big part of the programs that all of you are a part of now is going to require that you do evaluation and that you look at what the programs are that you are implementing and how they really are having an effect. And then you have to go back again and maybe change your intervention. Sometimes you actually have to go back to the beginning and redefine what the problem is to then know how to best implement it. And again, we're going to talk through some of those situations as we move through the conversation this afternoon. When we think about the optimal health model, the optimal health model is set up much like a target. High risk behavior, lower risk behavior, and then in the middle is no risk behavior. And the issue with optimal health is our goal and success is actually measured by the degree of movement away from higher risk to lower risk. And so again, regardless of where your community is, where the group of individuals are you have designed your program to interact with, no matter where they are, there's an opportunity to move them to an area of lower risk, thus optimal health. Again, and when we think about primary prevention, some people refer to it as risk avoidance, but basically it is to prevent the exposure to the disease or prevent the onset of any high risk behavior, thus a primary prevention. The secondary level of prevention sometimes is referred to some as risk reduction. In other words, you're involved in a high risk behavior, but there are steps that you can take to reduce the consequences of that either illness or that high risk behavior as you move towards a healthier place. And then treatment or tertiary third level is the result of this, either this illness or this high-risk behavior has led to situations that actually need treatment or intervention in that way. Now, how does that actually inform our sexual risk avoidance programs as we move forward with this? And I want to talk about that just a minute. The background for this is we've already said that primary prevention is the hallmark of a public health approach. That avoiding risk is optimal to reducing the risk, and that we know that health outcomes are generally improved when behavior risks are avoided during adolescence. Again, a lot of reasons for this, but many of you include in some of your programs discussion around the developing adolescent brain, the issues with early exposure, the issues with the increased harm from early exposure. And so again, this is not an unfamiliar topic to you, but the issue is that primary prevention or avoiding a behavior before it starts is going to be a healthier choice. I think it is critical, if you are involved in programs like this, that you truly believe that adolescents are capable of developing skills necessary to avoid this risky behavior, thus leading them to optimal health. I hope that the vast majority of you are involved with this program because you do like adolescents. It's really hard to have an effective program if really you don't enjoy interacting or being with adolescents. And I know just from my experience of working with so many programs and so many public health professionals in the adolescent world that truly those that are drawn to this particular area really do like adolescents, really do believe that they have the ability to develop skills and that they are an incredibly exciting group of people to work with. Many times the framework for looking at sexual risk and prevention of sexual risk, many times we have, I believe, divided it into a binary system. So it's either primary prevention, so teaching adolescents to choose not to have sex, or adolescents are already having sex, and so how do we interact with them at that point? And what I would like to suggest is, and again, I'm not the first person to suggest this, there are a number of scholars and authors that have written about this, but there is an in-between area that probably is more common, and it's a continuum of change. And the secondary prevention area, it really is important to define, because adolescents may venture into the issue of having sex, but they also then may choose to not have sex again after they've initiated it. And they may actually go back and forth. They may be at different points in the continuum a number of different times. This is all dependent on their past decisions, their experiences, their past sexual activities. And unfortunately, sometimes those can be involuntary and in addition to voluntary. And so it's important that we don't forget the fact that sometimes very early sexual exposure activity for adolescents happens against their will. And it's important that we deal with that. It's so critical that we develop our interventions based on the readiness to change of our audience and where they are. And again, I understand that it is impossible to know exactly where your audience is that you're preparing a program for. But what I would challenge you with is to, as best as you can, and I know that this is what much of the federal staff is dedicated to working with you, to determine where exactly are the groups of adolescents that you are dealing with, and where do they find themselves on their curriculum and on this continuum. And then based on that, you develop curriculum that best fits them where they are. I know that you are familiar with the stages of change theory, and the trans-theoretic model of behavior change fits so incredibly well here in this setting as we talk about this. The theory teaches that there are all kinds of stages. There are 5 stages of change that have to happen in order for there to be a change in behavior. And the first stage is what is considered the pre-contemplation stage. And that is the stage where the individual is not concerned that there's a problem at all. There's no intention of changing their behavior. They do not see their behavior as an issue or a problem. In contemplation, there's an awareness that there is a problem, and maybe that problem may be related to the behavior that they are involved with. And so they're starting to think about possibly a change in behavior. The next step is there's an intention to change within a specific time frame. And again, there may already have been some action towards change, but there's definite intention to change. And then the action stage is actually where there's been commitment to change, and there's been a success anywhere from a period of 1 day up to about 6 months. And then the last stage is maintenance, where there's sustained behavior that has changed and it's been longer than 6 months and it's ongoing. Now you can see from looking at this that this cycle can continue, it can jump back and forth, it can be at different places, and this is particularly true for adolescents whose physical maturity, social maturity, emotional maturity, they don't progress equally. And this becomes an issue that's really important to determine at what level, where are these adolescents, and based on that, how can we help motivate them to make a change in their behavior towards a healthier pattern for them. Another model that I want to talk a little bit about here that jumps in is that it's a health belief model. And it suggests that health behaviors, particularly prevention health behaviors, can be changed by addressing 6 constructs. And again, if you think back to the behavior change model, this is the area where change happens between contemplation, preparedness, and action. And what is important here is that there are 6 things that you need to address in order for someone to be ready to make a change. They first have to understand if they're susceptible to a problem with whatever behavior they're having. They need to know how severe that problem is. And then probably the most important is, what do I get out of it? What's the benefit of this? Why should I even make the effort to make this change? Another area is any perceived barriers to being able to make that change, based on friends, based on peer groups, based on parents, any situation like that. But another one is cues to action. What are the things that they can actually, what are some specific action steps they can take to make a difference? And then the last one is a sense of self-efficacy. I can do this. I can, there's something about that, I can actually make this happen based on what I have now in my hand, or who I have around me. Again, there has to be motivation, there has to be an opportunity, and there has to be ability. And so what is so critical about that is that our programs implement into them ways to help adolescents determine their self-efficacy, but also tools to use to help them see that they do have an opportunity to make a change if they perceive that this behavior that they are in is likely to lead them to an unhealthy situation. So to sum this up a little bit, one of the things that is important as we look at sexual risk avoidance education is to recognize that we may be talking to a group of adolescents who have not initiated sexual activity, but it's important that we also recognize and accept that cessation or choosing to discontinue sexual activity after having already started it is a viable option. Adolescents need to see that too, that they set healthy sexual boundaries, that they're able to communicate their decision to stop having sex. And probably most importantly here is that there's peer support for that decision. In what that leads to then is there's a belief and intention around making a choice or a change. Sometimes that starts with simply a decrease in the number of sexual partners or a decrease in the frequency of sexual activity. But what ultimately all of these steps lead to is moving to lower risk. It also decreases, we know it will decrease sexually transmitted infections and also decrease teen pregnancy, which again is one of the physical consequences that we're focused on when we're talking about and the grants that we have, that each of you have to implement in your communities. So I want to go back to the model that we were talking about before and walk through some examples or some steps around this. And again, if we think through this model and logically try to decide what is it that our adolescents are facing that we're talking to, and how is it that we develop or we determine an approach to helping solve this problem. One of the problems or the issues that these particular funding opportunities surround is the idea that there is a public health problem, particularly with teen pregnancy, but also, as we are understanding more and more recently, with sexually transmitted infection and disease. And we'll focus on that piece of it a little bit later. But again, that is the public health problem that is there. And the typical approach to this historically has been that unprotected sex is the risk factor. And so the way that we need to approach this problem is to make sure that adolescents know how to have protected sex. And I want to stop there a minute, and I want us to consider protected sex. When you think about protected sex, how do you get to if our goal is to get to the lowest area of risk, and we're teaching about protected sex, what does that actually mean? What does that look like? When we look at protected sex against pregnancy, again, the most common discussion item surrounds hormonal contraception. And again, we know from studies and from data that greater than 98% protection against pregnancy if the various forms of hormonal contraception are used consistently and correctly. When we think about pregnancy, the other prevention that we have is condom use. And there are a number of ways that condom use is defined or discussed, but when we talk about typical use for condoms, it's defined as 13 out of 100 couples are pregnant after a year. Now, the further definition of that that is important to understand, it does not mean that 13 times out of 100 when someone has sex with a condom, they're going to get pregnant. What it means is for 100 couples who use a condom every single time they have sex for a year, at the end of the year, out of those 100 couples, 13 of them will be pregnant. So again, pretty good protection when we're talking about pregnancy. But if you remember back to our earlier slide, we weren't only concerned about pregnancy, we were also concerned about sexually transmitted infections. And when we talk about protected sex against sexually transmitted infections, and we look at hormonal contraception, there is no protection against sexually transmitted infections from the use of hormonal contraception. And this is it is a big problem, and it concerns me greatly, because the best resources, the best methods that we have to prevent pregnancy that are very effective do absolutely nothing to protect against sexually transmitted infections. And I fear that there are many adolescents that think that as long as they don't get pregnant or get somebody else pregnant, that they're good. And they're missing the huge health consequence of sexually transmitted infections. What we know from looking at data around the use of both hormonal contraceptions, what we know is that when the most effective form is used, the use of condoms drastically decreases. We see this with LARC users. We see this even with those that are on birth control pill users, that they also do not use a condom. And the reason that this is important is because really the only hope of protection we have against any of the sexually transmitted infections is the use of a condom. Here's what the CDC says. It's on the CDC, the condom fact sheet, and you can find that on the website. But here's what they say about latex condoms. Latex condoms, when used consistently and correctly, are highly effective in preventing the sexual transmission of HIV, the virus that causes AIDS. They go on to say that when they're used consistently and correctly, they reduce the risk of transmission of some of the infections such as gonorrhea, chlamydia, and trichomoniasis. If they're used consistently and correctly, they may reduce the risk for genital ulcer diseases, but only when the infected area is covered by the latex condom. And lastly, what they say is when used consistently and correctly, they may reduce the risk for genital human papillomavirus, which is HPV. HPV is the virus that causes genital warts and cervical cancer. So it doesn't take much to recognize that our least common sexually transmitted infection is HIV, and that is the one that condoms are the most effective for. The most common one is HPV, where condoms probably don't show much effectiveness at all. And so it is a huge concern for us to simply focus on prevention of pregnancy without talking about prevention of sexually transmitted infections. The problem with condoms is that people aren't perfect. They don't use condoms consistently every time. They don't use them correctly every time. And it's particularly true, high school students who were sexually active, 41% did not use condoms during the last sexual encounter. This is from the Youth Behavior Risk Survey in 2017. 91% did not use dual protection with the last, dual protection meaning hormonal contraception as well as a condom. And so again, once they're on a type of hormonal contraception that is very effective against pregnancy, they really forget or don't think or are unaware of the dangers of sexually transmitted infections. We also know that adolescent girls were half as likely to use condoms with partners if they had been drinking alcohol right before sex. And again, we know all of the issues around the dual risk associated with alcohol and sexual activity that comes with adolescence. We also know that the use of condoms lowers with repeated sex acts with the same partner. And again, the longer that someone is with their partner, the less likely they are to use a condom. And again, some people might say, well, that's because that's a long-term relationship. They don't need that. But the other side of that is that there has to be some associated testing with that in order for that to really be the case. And also Again, there is not a certainty in many of those situations whether that is the only partner that the other person has had. Probably more concerning too is just the incomplete use, not using the condom during the entire act, either putting it on too late or taking it off too early. And again, there are a number of studies that look at this that confirm that there are consistent issues with using condoms. And again, the problem with condoms is not that that they don't work, it's that they aren't equally effective for all of the infections. And that particularly those infections that are spread by body fluid contact, the condoms work the best for those infections. But if they're spread by skin-to-skin contact, we don't have condoms that cover the entire genital area, so they're much less effective for these infections. And this is information that is critical for your adolescents to know in your programs. Again, it doesn't change the fact that they have the right to make their own decisions about what they do. However, they need to also be fully informed and have all the information, medically accurate information, before they make those decisions. I hope that most of you are aware of this, but I'm just going to review it very quickly if you're not. Lest you think that sexually transmitted infections are really not an issue in our country, they are a significant issue. And again, when we had the most recent survey released by the Center for Disease Control just last year, the estimate was that there were over 22 million cases of sexually transmitted infections diagnosed in the United States every year. If you do the simple math for that, that's about 55,000 people a day are infected with a sexually transmitted infection. Here's the problem, and this is probably what concerns me more than anything. What we know is that over 50% of the new cases are diagnosed in adolescents between the ages of 15 and 24. So the exact group of people that you are working with, the ones that you are hoping to help them make healthier decisions, are the ones that are at the highest risk for these infections. And we have to begin to have the conversation with them where we're really promoting health, we're looking at optimal health for them, and we're just not just concerned about preventing them from having a pregnancy. So let's go back to the original comment that we discussed. When you walk through this in a really logical fashion, what's important to understand, and what I want to use is using the optimal health model here to help us make some decisions around the way we're going to tailor our programs. What the public health problem is: teen pregnancy, sexually transmitted infections, and diseases. And initially we said that the risk factor was unprotected sexual activity. What I want to challenge you with is that if we are really trying to get to a place of no risk, then if we just use unprotected sexual activity as what to focus on, we're going to miss the point here. And I would argue that discussing the fact that sexual activity introduces risk into an adolescent's life. And it's important for a number of reasons. And I think that the conversations that we need to have with adolescents, and this is the public health message, this is the one that is given to everyone about what is the healthiest choice, is that delaying sexual activity until, and this is how the CDC describes it, they're in a long-term mutually monogamous relationship with an uninfected partner. That is where you can be in a situation or state of no risk when it comes to sexual activity. And again, risk factor identification here. Now, you will have opportunities where you are talking to adolescents who have not yet made that decision to have sex. And this conversation is incredibly important to them. This is the population-wide primary prevention message that is very important. However, the reality is that there are a lot of other situations that come in, and you are going to find adolescents at a variety of different places on this optimal risk model. So let's say, for example, that you have an adolescent who is sexually active. They've already become sexually active. When you think about that adolescent, one of the consequences, or one of the things that you want to discuss with them is where are they on this aspect of no risk? You know, again, helping to have the conversation that just because that you have been sexually active, you may want to choose to delay further sexual activity What are the benefits of delay? What is the need for peer support around this? Remember the model that we talked about when we went to the health belief model: contemplation, preparation, action. They may be in a place of pre-contemplation where until they've heard your presentation or you have talked to them, they had no idea there was even an issue, because they had been taught as long as they used a condom, they were going to be okay, or nobody ever said anything to them about it. Or as long as they were using something to not get pregnant, then everything was fine. Maybe as a result of your conversation or your program or how you present this, that might lead them to a time of contemplation around what is it, maybe this behavior is something I need to think about or look at. In order for that to work, if you remember, that's where they need to have tools and understanding. And what's in it for me? What are the benefits of this? Is there any reason why I should make this choice? Let's say that instead, as you're having a conversation with your students and you're talking through all of this, you recognize that, yes, they're having sex, but it's protected sexual activity. So where does that put them on this risk model? If they're having protected sexual activity, are they at no risk? Are they at low risk? Is it high risk? And I think the thing that we need to understand here is that, again, the contemplation, the preparation, and the action model, as we're talking through this with them, this would place them really between low risk and high risk. Why do I say that? Well, it is because that depending on what type of protection they're using, they may be at a fairly low risk for getting pregnant, but the majority of time that puts them at a high risk for getting a sexually transmitted infection. And so they really are somewhere in between that. And as your conversation is there with them, your idea is, and what you need to do is think, okay, how can I get them to a place or help them to start to at least think about being in a place of increased health, decreased risk? How do I move in that direction in an optimal health model? The question to ask at this point is something along the lines of, you're having protected sex. Is not having sex an option for you right now? Why would you ask that question? Well, part of the reason for that is that it brings them to a place where they may step from pre-contemplation to contemplation. Okay? At that point, they may say a number of different things. Okay? There are a number of aspects to that. I am having sex. I'm protected. It's not an option for me not to have sex right now because I like having sex. Okay, that is an answer that may come as you're having that conversation with adolescents. I'm protected. I'm doing all these things. It's consensual. I enjoy it. I want to have sex. Okay. At that point, what is really important is that you confirm the appropriate use of contraception. You confirm the consistent use of condoms, encourage testing for sexually transmitted infections, talk about decreasing number of partners, helping them see the risk, the fact that they're not at no risk at this point, particularly depending on what their age is. But that's the conversation that asking that question leads you to. Well, what about this? What about if what they say to you is, it's not consensual. It's not having sex is not an option for me because my boyfriend is forcing me to have sex. Or my boyfriend says he would break up with me if I didn't have sex with him. Or more than that, someone else is forcing me to have sex. Again, we may not get the answers to those questions. And in a classroom setting, the way to discuss this is really using scenarios to go through those scenarios. As you answer this question, what are some reasons why not having sex is not an option for you right now? Think through that. That's an incredibly high risk, obviously high risk situation at that point. Non-consensual sexual activity is significant. It's serious regardless of what age it occurs at. And I think that at that point, the discussion of recognizing unhealthy relationships, there may need to be involvement of social services at that point. That probably is going to be beyond the scope of your whole conversation with your whole classroom. But again, it's the time that needs to be addressed to help people see that there are more aspects to this than just protecting against pregnancy or protecting against sexually transmitted infections. What about the situation where it's protected sexual, it is consensual, but that's physical, and we've already talked about the fact that optimal health involves more than just your physical health. It involves your emotional health, it involves social health, it involves your mental health, your spiritual health. Sometimes adolescents, in thinking through this, the question that can be asked to help them think, okay, well, I'm having sex, it's consensual, I want to have it, but how do your friends feel about you having sex? What about your family? Where are the issues there? Is there family social conflict that has come in as a result of this? And where does that place you in a healthy situation? And I think that many times discussing the importance of social relationships, the source of the conflict, what are the options that you have to really reduce this conflict? Is the source of conflict something that you should consider? And again, you're back to the same pre-contemplation, contemplation, action aspect of that. What is in it for me? Do I have the self-efficacy to make a choice or make a change? Do I want to make a change? What's the motivation for me to make a change at this point? The situation where there's protected sex and it's consensual sexual activity, maybe there isn't a problem with their friends or their families, but what about themselves? How satisfied are they with their relationship right now? Do they feel like that they're where they should be? Is there emotional turmoil around it? What is their emotional health when it comes to the relationship that they're in? And again, if there are situations surrounding that, that maybe the referral to community resources for counseling should be important. But what is probably most important is as we're working through the model with our adolescents and we're teaching them, is helping them to think through the different steps and the fact that this decision to have sex is a big deal. There are a lot of things around it that are important when it comes to making this decision. Certainly when we come to the situation where they're having sexual activity, there's multiple partners. Again, it's incredibly important, definitely a high-risk situation, incredibly important to find out if there's coercion. Again, though, it's important to ask the question, is not having sex an option for you? I mean, it may be that they are enjoying what they're doing. And again, in that whole stage of making the decision, we have to determine where they are in making their decision and helping them. Again, our ultimate goal is to help them, lead them towards a healthier lifestyle, healthier decision-making, healthier behaviors that lead them to future health. I think in that situation, if they are at that point and they aren't wanting to make any changes at all, again, we're back to the confirming the appropriate use, consistent use. Really important to talk to them about the dangers of multiple partners. So putting all this together, when we think about all the aspects that go into optimal health, there's social health, emotional health, physical health, intellectual health, there's spiritual health, all of those things pointing towards this. And again, what we're thinking about and what we need to do interventions for, we think about the risk for pregnancy, the risk for STIs, but also what are the conflict risk, social types of conflicts. And with multiple partners, what are the issues of trust? What if there's unhealthy coercion? All of those things come together to help determine optimal health. And all of these components can be woven in as a part of the presentation and to your adolescents. Again, with the majority of the focus being towards where most of your audience, where they are in that situation. I'm going to stop now and see if there's any questions. I don't know if any questions have come in through the chat box. I'll turn this back over to see if, I don't know if we had any questions that came in or not. If you'd like to ask those out for me, I can help with that.
Sure thing. So we did have one. As you were going over risk factors for sexual activity, someone asked, what about other risk factors that aren't physical?
Okay. And so again, it's absolutely true. And I think that's one of the problems with just focusing on the physical risk factors. I think those are the ones that we have to focus on those because they are the ones that are talked about the most often, that adolescents are concerned about. But I think that that's where particularly using an optimal health model is really good for this, because you can help them see that optimal health is more than just physical health. And so as you're talking through that, developing questions that help them see how could a sexual relationship affect their emotional health? How could it affect their mental health? Does it affect their their spiritual health at all? What are the other aspects that come in? And again, help them see that these are sometimes cause and effect, and those discussing those kinds of things actually help to bring them to get to a place where they may be willing to make a decision about a behavior change.
Great, thank you for that. We have some more coming in, so I'll read the next one. They said, thank you for such a fascinating presentation. And their question is regarding working with highly traumatized populations, such as adolescent victims of crime, sexual abuse, etc. Could you please provide any examples or additional resources for ensuring our SRAE program is trauma informed?
I think that there are a number of really good resources out there about trauma informed. And I think that one of the things that I have seen and experienced is that many times in your programs for trauma informed, much of the interaction that really makes a difference or makes an impact ends up being a one-on-one or small group setting. That it is very difficult in a lot of ways to talk about situations like that. If your entire group is trauma informed, it's a little bit easier, but if you have a couple of adolescents in the group that are, and the rest of the group doesn't relate to that, that makes it a little bit more difficult. I think it is very important that you always stress that many adolescents don't have the choice about when they initiate sexual activity. And as a result of that, that can cause a lot of other things. But again, if they are at a point where they can make a choice about continuing with that, then that's where the self-efficacy comes in. That's where the ability to make those healthy decisions comes in. And that's really, really important.
Perfect. And then one other question, it's a clarifying question regarding the optimal health model. And they want to know if that model is a combination of sexual reduction and sexual risk avoidance strategies.
You know, I think that the optimal health model is actually more of a model about approach to sexual health than it is about sexual risk avoidance or sexual risk reduction. So I'll say yes, and but let me explain that a little bit. I think the critical thing is there is not going to be, never is there going to be a one fits all curriculum. That again, the importance of this and what we're finding is that it's much more important to determine where your audience is and approaching it that way. I think what the optimal health model does is help people see that everybody fits somewhere. That yes, you would like people to have avoided risk behaviors all along, but if by chance, for some reason, whether a fault of their own or not, a choice of their own or not, they have not made that choice, it doesn't mean they can never be healthier. And so that's where that process comes in. And the reality is that you're going to find adolescents all along that spectrum. And so the optimal health model is more set out to help you determine the approach of your curriculum based on who you're talking to. Remember, though, that the optimal health program is based on a primary prevention message that is a population-wide message. That means that everybody needs to understand that the healthiest choice for them is this. And then wherever they fit, we're helping them get to a healthier choice. It's very much the way all of our other disease models are set up. I laugh because every time when we think about heart disease, which is something that's a huge public health issue people talk about. And again, some of the primary prevention issues that are talked about are, exercising more, changing their diet, different things. And it doesn't really matter what I have done in the past year. My doctor always has the conversation with me about exercising more every single time, whether even after all these years when it's been such a difficult thing for me to pick up, it still doesn't change what the primary message is to me, that this is going to be the healthiest thing for me. I think it's important that we look at that as we move along.
Okay. And then one more question came in as you were explaining that one. So in regards to the spectrum you mentioned, how do you measure where they are on the spectrum, and are there any samples available?
I think that I think that your community-wide samples that you do when you do a needs assessment is going to help you with that. I think that the age of the adolescent is going to help you if you can use youth risk behavior surveys for if you happen to have them for your state or for your community, and you look and see what percentage, let's say you're talking to 6th grade students and you look at the middle school survey and you see that in your community or in your state that 97% of the kids have not initiated sex by the time they end 6th grade, that kind of thing, then that's going to give you some idea of who you're talking to. If instead your program is to adolescents who are in aging out of foster care, or adolescents that have been involved with the juvenile system, things like that, who already just from what they have experienced that they've been involved sexually, and your program it doesn't make sense that 100% of your focus is on to delay having sex, because that's not the point. Yours, it would be more along looking at sexual cessation. What are the issues around this? Why is not having sex an option for you? So I think that we always need better data. There's no question that we always need better data. And that's why it's exciting to see new programs come out that are targeting higher risk populations. And I think as we study those, we'll be able to see what programs are the most effective for addressing those issues.
Okay, thank you for that. Next question is, what are some of the assets needed to move a team toward risk elimination?
Well, there are people a lot smarter than me that have put together lots of lists of assets. I think that the one that we've all used over and over again is looking at the 40 skills or risk of behaviors and risk protective factors and things that are not protective factors for adolescents for making healthier decisions. I think that there are other models that are out there that can help you look to see. We know that supportive adults are critically important. We know that a peer system is critically important. So again, there are models out there that help you look at that, but many times the answer also comes from having those conversations with the group of adolescents that you're talking to. I have learned so much from adolescents that I have taught when I stop and ask them to say, what do you think it would help you to make a decision about changing your sexual behavior habits? What is it that would help you do that? Many times what we have seen them say is to have an open and honest conversation with adults about that. If you remember some of the surveys that were done and have been repeated, a lot of times adolescents say that if they could have a conversation with their parent or someone that's an adult, it would help them make decisions about this.
Next question, are there any case studies or examples of healthcare organizations successfully utilizing the optimal health model that we can learn from?
And I think that that is something that I want to turn back over to, that we will answer for you later and move towards you. I know that I cannot make that answer that myself without, because I'm only aware of a group of programs, but I do know that FISB and some of the other organizations that have been working with them would be able to point out a number of organizations that do have that. I think that the Ascend organization also does a lot of work around optimal health and optimal health models, and they would be able to point you in some directions. And I think there are other organizations that can do the same thing.
And that's the last one I see. Does anyone else have questions for Dr. Foley?
Dr. Foley, would you mind showing us your contact information?
Oh, you're right. That's another slide, isn't it? Hang on. Sorry.
No worries. I just wanted to make sure everyone had an opportunity to take down your contact information should they need it. And if we don't have any additional questions, we want to make sure we give everybody enough time to submit any last minute questions. Looks like we have another one there, Azalea, if you want to field that one.
Yep. Are there any online curricula you can suggest?
And I don't know if that is online curricula for the optimal health model or just overall. I'm not exactly sure of the question. There are a lot of curriculum that focus on looking at optimal health and looking at a lot of that is what the sexual risk avoidance curriculum does in implementing that. There is not, as far as I know of, actually an online curriculum around optimal health specifically. That is something that has been worked on, and I honestly don't know if that is a project that will continue, but I believe that there are a number of organizations that have said they would like to develop something around the whole concept of optimal health that could help to inform the field about that.
And I believe that's the last one we have.
Well, thank you again for your attention, and I wish you the best. I'm excited about seeing the results that your programs are going to have from implementing this, and I really look forward to ongoing conversation around this topic. And again, it's something that I'm very passionate about and have spent a large part of my life working with, and looking forward to seeing the things that come out of the field. So thank you again.
Thank you, Dr. Foley, and thank you, Azalea, for helping us moderate today. So with that, we'll go ahead and end this session and give you a few moments of your afternoon back. You do have a 15-minute break built into this, so you'll be joining us in your next track 1 session, which is a field talk. That will be from 3:45 to 4:45. So we'll see you in that track here in just about 25 minutes. Thank you again. Have a great afternoon.